is Emilio Torres. First, I would like to thank you to the opportunity and to the invitation to present our work here. And the subject is back cross-linking or cross-linking for infectious keratitis, which is used for, of course, infections. So this term, back cross-linking, was first defined in 2012, so quite a long time ago, and it means photoactivated chromophore for keratitis. So it includes both procedures that would use riboflavin as a chromophore or also as rose bengal, for example. And infection is a growing problem everywhere. Here you see the numbers of infectious causes, deaths, and the most worrying is that we over the last 30 years have not developed a lot of types or new types of antibiotics, and we see there is a discovery void over the past decades. And for our surprise, and this was one of our studies as well, in some recent studies up to 50% of bacteria were already resistant to the last fluoroquinolones that are available. So we need to find other alternatives for the antimicrobial therapies. And one of them is the use or the combination of UVA and the riboflavin. This has already been proved to be disinfectant. This was used at first to cleaning water in remote areas, and the mechanisms or the hypotheses of mechanisms are basically three. So the first one would be the oxidative stress that would cause disruption in the cell membranes, but also a second effect would direct damage the DNA or the RNA, and a last one, which is called steric hindrance, would bring increased resistance to digestion. So moving to the first cases, in 2008 we saw the proof of principle in some 4 or 5 clinical cases, and here you can see 10 days after back cross-linking how a cornea was healed or the infection was resolved. And also in vitro data, so here the lab data, which show a great inhibition of pathogens, so the bacteria were killed, and this was done with Dresden protocol at that time. So we know that back cross-linking works, but we need now to understand more how to enhance this application. So the first is about the spectrum. Here back cross-linking has a great advantage because independent of the experience, and even if you have a diagnostic dilemma, back cross-linking can still be beneficial. And why? Because it is able to kill bacteria and fungi simultaneously, so both at the same time. So here on the last studies we see that back cross-linking was able generally to kill bacteria in around up to 98% in vitro, and depending on the energy, and that we will speak a little bit later on, but fungi was less efficient, but we could around 60 or 70% in vitro, so the killing rate in vitro would be around this from most of these studies that we have so far. However, the same, so this killing rate does not happen with acanthameba and also does not happen with herpes simplex, so they cannot actually be devastating in some situations because the energy required would be so high. A second point that is important to mention is in which stage of the disease should make sense to treat or to use by cross-linking. Would we treat rather early ulcers or the advanced ulcers? And from this article, we started to find out exactly where this technique would be best. So the authors here noted that early ulcers did not require additional treatment. And here you can see some cases in which the pair cross-linking was used. So from this study, we could learn that infiltrates or ulcers up to 2.5 millimeters, or in other words, small infiltrates, tend to clear quicker after pack cross-linking. So the question is, does it make sense it early ulcers or the late ulcers? And here we could see that it makes sense to rather treat early ulcers. Another point that at the beginning we were not aware is the fluorescence and the interactions that it would have. So we usually use it to improve. I mean, fluorescence is usually use it to improve the visualization during the slit lamp examination. The problem is that riboflavin and fluorescent, both of them have high absorption rates in the same wavelength that is used for cross-linking. So you can see here on the red markers, and these can explain some reasons why we saw different outcomes in similar treated cases. So why? Because they compete with the other and makes the killing rate of the bacteria or the pathogens lower. So in here in this graph we could see that this was almost dropped by half if they were used together. So the message here is not to stain the ulcer prior to cross-linking with riboflavin. So this is an important point. And the last point would be to which extent would we be able to accelerate cross-linking using for infectious keratitis. So actually this need to make it faster and able to treat ulcers came a few years ago, and it the end of this history is that in 2019 there was the launching of the cross-linking at this slit lamp, and there would be many advantages for using this. First, because it would reduce costs and also would separate infectious cases from regular surgeries, and also this one device could be used for several locations, and those reasons would be rather good reasons to use in developed countries, but also in underdeveloped in developing areas. It could be very useful as well, because it could serve those remote areas, increasing the coverage and at the last extent accessing or democratizing cross-linking. There were already two problems in which we could think about when using it at this slit lamp. The first is the time spent at the slit lamp. So we just talked about that, and we saw that we can speed the process to the cross-linking up to 10 minutes. But for infections, it could actually even increase it more. So here a study showing that the efficacy of cross-linking or the pack cross-linking differently from the cross-linking can be accelerated, still having or still maintaining the efficacy. So this is not a problem for treating infections. The time can be accelerated. And the second would be the risk of infection. So when we understand the risk of infection and the mechanisms of pack cross-linking, we understand that cornea, after the end of cross-linking procedure, is almost sterile because we kill all the microorganisms, or at least most of them. So this would not be a problem. And because of this, here you can see now one of the first patients that we did cross-linking at this, or pack cross-linking at this slit lamp, and now this was published in 2021. So I was saying before, and this is one of the reasons, because pack cross-linking works quickly, that different than standard cross-linking for keratoconus, in which we see here on the graphs, on the columns, that when we accelerate the process, we decrease the efficacy. So this is for keratoconus. So different from this, pack cross-linking can be accelerated, maintaining still a good bactericidal effect. So the killing rate remains high even if we do it faster. So the first series where cross-linking or pack cross-linking was used to treat keratitis without antibiotics was done with the Dresden protocol, so 30 minutes. But as I said, the goal has been to make it faster. So this was a paper from 2018 from Boris Kneiser from Israel, where even in medium ulcers, it was an adjuvant treatment. Even in medial ulcers, accelerated cross-linking was effective. And here we can see even those big or advanced infiltrates were successfully treated. And finally here, our recent article, we evaluate how these treatments, or the adjunctive treatment or pack cross-linking treatment, could be compared with antibiotics alone. And what we could see, that there was a faster healing when we combined cross-linking with antimicrobials. Instead of 16 days, we could reach a healing in only 9 days. And here some of the cases that were published. Also, another and a multi-center study that we have been doing for some years now were recognized last year at the ESCRS as the best poster or the best paper. And this is a multi-center study in which we evaluated whether the infiltrates were treated only with antibiotics or only with antimicrobial therapy or only with pack cross-linking. And this was the first study, and this is the first study to evaluate such results. And as we can see here, ulcers up to 4 millimeters were treated and then randomized in whether only pack cross-linking or only medication. At the baseline visitation, the infiltrates were similar in both groups, and it was also the same for best corrected visual acuity.
Tienes una cita presencial con tu preparación académica, con los profesionales de la salud visual de América Latina, con los negocios.
Asegura tu cupo en franjafedopto2021.com inscripciones.
Enfrentando eficazmente la era digital.
The most commonly identified antimicrobial were the gram-positive cocci, but we had also some cases of fungi, and the results after only PEC cross-linking was that we could not observe any difference in the epithelialization time, which was in our study about 7 days in both groups. And also the best corrected visual acuity at the end was similar in both groups. So here you can see some images in which PEC cross-linking was used to treat keratitis. So the left image, the day 0, on the right, a month after. But of course we also had some complications, and these happened in both groups. So also groups in which only antimicrobial therapy was used, but also one in the group in which PEC cross-linking was used. Overall, even if we excluded these 2 patients, we had a healing rate only with PEC cross-linking in almost 90% of the cases, so which was fantastic. And when we see the cumulative distribution, we could even see an advantage over the PEC cross-linking. That's another experimental study now, not clinical but experimental, by our group, which also shows how to achieve a maximum killing rate using PEC cross-linking. And what we have observed is that the increase of the energy is the point that we need to take a look at. So as we increase the energy, we also increase the killing rate, and that's the key role here. So this was so big. This here is a paper from ophthalmology, and that exemplifies exactly why people are reticent about this technology. And even in very good journals like ophthalmology, the results that are published nowadays are in general using lower energies of UVA, and that's the reason why the PEC cross-linking has not been shown in many studies to have good results, because the energy used so far has been lower than we would need. So this we published last year in ophthalmology, bringing attention to this point, which is the key point here probably. So as a final conclusions, PEC cross-linking or cross-linking for infectious keratitis addresses important issues of the future. For example, antibiotic resistance, the access to healthcare, costs and compliance issues. It can be accelerated to 3 minutes, is still having efficiency. So this is different from the treatment from cross-linking, and there is a big advantage here to PEC cross-linking, favoring PEC cross-linking. It is highly efficient in bacteria and fungi, and the treatment would be better the earlier, so the earlier the better. And lastly, cross-linking alone seems to have a good effect, and this we show in our multi-center PEC cross-linking study. So with this, I would like to thank you everyone for the attention and the invitation here to participate. Thank you.